Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice, that is, Hatvet's YouTube channel. We are thankful to our honorable speaker and session moderators for sharing their valuable time and knowledge with us.
Dear participant, today presenter Dr. Akshaya Maller. She grew up in Chennai, India. After completing high school in Chennai, she moved to United States in 2007 to pursue her Bachelor of Science in Biology at Texas Christian University in Fort Worth. She then went to veterinary vet school at Iowa State University after graduating with the Doctorate of Veterinary Medicine in 2015. Maller completed a small animal rotating internship from North Carolina State University. She practiced at a high volume of spay, neuter and low-income clinic for 1 year before joining a Madison veterinary specialist and emergency in Madison, Wisconsin in 2017. Dr. Maller is currently an emergency and critical care veterinarian at MVS. Dr. Maller interest among emergency medicine include polytrauma cases, parvo puppies, sepsis, SIRS, blocked cat, and toxicity. She also has a special interest in shelter medicine. Today's topic is on toxicity of rodenticide, paracetamol, and organophosphate in small animal and its management and update 2025. And she is actually, while presenting, she used to be quiet. And whenever she get an emergency case, Maller, entirely, she became, active. And she will follow the protocol of CPR and, she taught us so many things in our critical care unit. And apart from quite interesting news is Dr. Amshini, diplomat in emergency critical care in UK, a diplomat in emergency critical USA. She is the only veterinarian available in India. And she is also interested to attend Maller presentation. She is also available. She is also ready to interact any questionnaire by the participant. And I want to thank Amshini also in these occasions. I welcome all the participants and the co-host and Maller. And I request her to go ahead and present the topic.
Good evening, everybody. It's a pleasure to talk to everybody today. And thank you, Dr. Chandrasekar, for putting this together, for inviting me to speak. I think it's going to be a lot of fun. So like Dr. Chandrasekar said, today we will be talking about management of toxicities in small animals. A sort of overview of my presentation, I am going to touch base a bit about just the general approach in managing toxicity cases, because there are a lot of similarities. And so if we have a general idea of how to approach those cases, then we can extrapolate that to, any sort of toxicity. It's difficult to know everything about all the toxins in dogs and cats. So never be afraid to open a book, to look at online resources about specific toxicities, but it is important to know potentially what are toxins or what the toxins are that can affect these animals, so that when an owner brings a patient in and they say that they gave a certain medication or it was exposed to a certain thing, that is a potential toxicity. So when talking about a toxicity, the first and foremost thing is trying to get an accurate history on that patient. So is that patient stable? What clinical signs is it showing? And then trying to figure out when that patient was exposed to a toxin. So was it within a few hours? Was it a few days? Because that's going to determine how you are going to treat that patient and what you need to be concerned about. And then also trying to figure out what that toxin is, how much did it get into, or at least trying to figure out what sort of environment that patient was in, so that you can figure out what toxins it could have been exposed to. Then doing a good physical exam, again, to ensure, is that patient stable? What are its vitals? Do we need to be acting quickly? Do we have time? Can we induce vomiting? Can we put this animal under anesthesia? To then determine, what are our options in terms of treatment. Once you've established potentially what the toxicity is or have an idea of suspicions, you've done your physical exam, then you're going to think about decontamination. How do we reduce the amount of toxin in the patient's system, either by reducing the absorption, getting it out of the GI tract if that's how the animal is exposed, or if it was on the skin, how do we reduce that? And then how do we get it out of the system quickly, so through the kidneys, to breathing, things like that. So when we talk about reducing absorption, there are a few ways that we could do that. One is, these are primarily for GI, like ingestions, GI toxins, is emesis, so inducing vomiting. There are a few ways that we can induce vomiting. They differ between dogs and cats. So in dogs, one is hydrogen peroxide, not my most favorite way to induce vomiting because it might not be very reliable. The way hydrogen peroxide causes vomiting is it causes irritation through the esophagus and the gastric wall. So sometimes it can cause just gastritis, GI ulceration. So not very safe, but may be an option if a client calls or somebody calls and they're very far away from your practice, or you don't have access to other emetics, then you can consider hydrogen peroxide. I would say never use hydrogen peroxide in cats. I've seen owners try this, and then cats develop really bad GI ulcers and can bleed out through their GI tract. So something that I do not recommend doing. And then also being very careful with dosing, so not overdosing them with hydrogen peroxide, again, because we can cause a lot of damage to the gastric and esophageal wall. A little bit more safe, or actually more safe, is apomorphine. Apomorphine works on the dopamine receptors in the chemoreceptor trigger zone in dogs. And it's pretty reliable. You can get vomiting within 10 to 15 minutes. And if for some reason they get severe side effects, so a lot of CNS suppression or depression, you can reverse this with naloxone because it is an opioid medication. Typically, the dose I use is a 0.03 mg per kg IM or IV. I'm not sure if this is available in India, but ropinirole is a newer product over the last few years available in the US, and it is a medication that you can drop into the eye of the dogs to induce vomiting. So it's really convenient for like aggressive dogs or dogs that, you just can't get IV access in or can't get very close to. It also works on the dopamine receptors and can cause vomiting within 12 to 20 minutes. And there's a little dosing chart on their website or on the label for different weights of dogs. For cats, it's a little bit harder to induce vomiting. We don't have any reliable emetics. This is because of the differences in receptors in their chemoreceptor trigger zone. So apomorphine, ropinirole don't work well in cats. But what we can use is alpha-2 adrenergic agonists like xylazine or dextrometor. Sometimes you can also use hydromorphone IM. All of these drugs are given IM. They're all reversible, so that's great if they don't induce vomiting. And I would say my luck is about 50% of cats will vomit and 50% of cats will just become sedate. But the advantages, they're all reversible. And so it's definitely worth a try to try and get whatever the toxin that they've been exposed to out. Other things you can do is consider activated charcoal with or without sorbitol. Activated charcoal will bind to certain toxins, so they don't work with everything, but can bind and reduce absorption of certain toxins. And then we'll talk about it in just a minute. If it has a cathartic added to it, it can help eliminate the toxins quickly from the system as well. And then you can always consider gastric lavage. This does require putting your animal under anesthesia. And so it is something that you have to take into consideration. Is that animal a good candidate to put under anesthesia? How much of the toxin is ingested? When have they ingested the toxin? So sooner, so within about an hour of ingestion, you have a higher chance of removing a lot of the toxins via gastric lavage, but after about an hour, that amount that you can remove drops significantly. And so there is a lot of work that goes into it. So I would just consider what is the risk and benefit of doing anesthesia, doing a gastric lavage in these patients. Definitely, if you're doing it, they have to be intubated because risk of aspiration pneumonia is very high. One of the advantages is if you do gastric lavage, once you have lavaged it, you can put activated charcoal through the orogastric tube into the stomach, because sometimes animals would not want to eat or activated charcoal on their own, and then you're trying to syringe that into their mouth. So if you have an orogastric tube in, it does make that a little bit easier, but not something that I rush to do. I definitely consider my options before approaching gastric lavage. The other thing that I don't have on the slide is if this was a dermal exposure, bathing the animal is also can be quite helpful. So if they were, a cat that was exposed to lilies and has pollen all over its face, just wiping the cat down or bathing the cat. If it was certain organophosphates, if they were exposed to the aerosol type versions of those, trying to bathe those animals can be quite helpful in decontamination as well. The next step is trying to enhance elimination. And this is important depending on the toxin you have. So I have fluid diuresis there. Now, fluids are not necessary for all toxins, and we have to be really careful about that because some people will say, okay, well, we're going to try and flush the toxin out of the system. Well, if the toxin is not excreted through the kidneys, fluids really don't have any importance in trying to get that toxin out of the system. It can actually be detrimental if we start these patients on really high rates of fluid and put a lot of stress on the kidneys. So knowing your toxin and deciding if fluids are going to be helpful is important. Fluids can be a part of your supportive care to help with dehydration, to help with, just pressure or vascular support, but being very cautious with how you're using those fluids and the rates of fluids you're using. Cathartics, these are medications that will increase transit time or decrease transit time through the GI tract to help the patient defecate or eliminate the toxin quickly. So sorbitol is one of the things we use. So typically we'll use activated charcoal with sorbitol. So I usually our first dose of activated charcoal will have sorbitol in it. Just be mindful of checking your sodium because it can sometimes cause hyponatremia. Other things that can be used as well is intravenous lipid therapy, which we'll talk about in the next slide. And then if you have access to hemodialysis or hemofiltration, that can be also really helpful in our really severe high dose toxicities. But it can be cost prohibitive and also time prohibitive. If the toxin was ingested many hours before the patient is brought in, it may not be a good option for removing that toxin. So with intravenous lipid emulsion therapy, these are typically used with drugs that are lipophilic, that tend to bind to fat. It's not fully known how it works. Thought process is maybe it's like a lipid sink where it binds the toxin and kind of removes it from circulation or removes it from being able to have its toxic effects metabolized and things like that, but I don't think we really know. They say that use it in toxins that have high morbidity. If you've done other therapies and it's not working, to use lipids, but you can use them, right off the bat if a patient is quite clinical. It's generally pretty safe. It can cause a lipidemia, it can cause pancreatitis, but it can also be really helpful. So just using it, if you have access to it, using it sort of right off the bat is not wrong. Our dosages are from human medicine, and this is the dosage or the protocol that I was taught to use. So you use a bolus dose, you give that over a couple of minutes, and then you start a CRI over 30 to 60 minutes, and I base that off of the volume that patient is getting and kind of the risk of fluid overload if that animal has evidence of heart disease or other comorbidities. And then you can, if you've got a good response to the lipids, you can repeat the dose in 4 to 6 hours, depending on how that patient is doing. But making sure to check if that patient is lipemic before giving the lipids, and if they are lipemic, you wait, you give it, you check it again, and you give it later, or you don't if they're remaining lipemic. So these are some of the toxins that will respond to lipids, but I've also used them with marijuana toxicities, with certain mycotoxins, and sometimes NSAIDs can also be treated, or it could be an additional dose, additional resource if you don't have access to dialysis or things like that. And I'm just going to briefly give you a list of hemofiltration. So if you have access to dialysis or TPE or charcoal, it can really help with our really high toxicities even before those patients become clinical. So just knowing which toxins can be used or eliminated with hemofiltration is helpful. And I know Dr. Chandrasekar does dialysis. So if this is at your facility, maybe things to consider. So just getting into specific toxins, today we'll be covering paracetamol, acetaminophen, we'll do rodenticides, and then we'll also do organophosphates and carbamates. I've dealt with both acetaminophen and various rodenticide toxicities. I'll be very honest, I have not seen an organophosphate toxicity. It's just not something we see very commonly where I'm at, but I do have experience with the other two quite extensively. So acetaminophen, paracetamol, used quite commonly in humans for pain and fever relief. And it can be a pretty good drug in dogs for pain and fever relief at a typical dose of 15 mg per kg. You can use that up to every 8 hours. But at higher doses, it can be toxic to dogs. And then in cats, it's something that I would not recommend using in cats. They can get sick at lower doses. They reported at 10 mg per kg, but we've definitely seen toxicities at lower doses. So just something that we do not recommend using, and it can be quite rapidly fatal. So how acetaminophen causes toxicity is once ingested, it goes through kind of 3 pathways where it is converted into either non-toxic or toxic metabolites. The pathways through which it goes, glucuronidation and sulfation pathways, it becomes its non-toxic metabolite. But when it is converted by cytochrome P450, it becomes this NAPQI toxic metabolite, which then can also again be broken down by glutathione into a non-toxic metabolite. Now, what happens is at higher doses or chronic doses, these pathways get depleted. And so then we have a buildup of that toxic metabolite, which then becomes a problem. In cats, they already have lower stores of the glucuronidation and sulfation pathways. So that's why they're a lot more susceptible than dogs. In dogs, we don't exactly know why, but in dogs, acetaminophen tends to affect their liver more and cause more hepatocellular injury, whereas in cats, it tends to affect their red blood cells, causing oxidative damage and hemolysis. So a few clinical signs that we can see, and this can be very variable depending on the dose and timing of ingestion, but sometimes you can see vomiting, trembling, anorexia, abdominal pain, icterus or jaundice. And then at really high doses in dogs, we can also sometimes see methemoglobinemia, which will then cause hypoxemia, cyanosis, so on and so forth. In cats, again, we'll see some of the similar signs, but cats, they often come in respiratory distress because they have a much higher risk of developing methemoglobinemia. And they're coming in with cyanotic, with like purple, muddy mucous membranes, and they also get edema of the face and paws. And that's one of the more classic signs of acetaminophen in cats. So if you see a cat in distress with facial edema and paws, That is one thing to clue you in to talk to the owners of, have they been exposed to paracetamol? Did the owners give it because they felt the cat was in pain or febrile, or was it prescribed wrongly? So just, they may not always have it, but if they do, then that's something you need to kind of have a light bulb go off in your head to talk to the owners about that specifically. Recommend doing some diagnostics. A CBC in cats specifically can be pretty helpful in gauging or assessing for methemoglobinemia. So looking for a brown tinge to the blood. You'll also see hemolysis from the breakdown of red blood cells. And it sometimes is really nice to kind of make little crit tubes or hemocrit tubes to monitor your methemoglobinemia as you're treating. It can also give you an idea of prognosis. And then also to measure anemia in these patients. A chemistry can be helpful to assess liver damage in dogs. You can see an elevated ALT in cats, but it's typically from hypoxic liver injury rather than from direct liver injury from the acetaminophen toxic metabolite. And then you can see evidence of reduced liver function in dogs as well. And then hyperbilirubinemia in cats is often associated with hemolysis rather than specific liver damage. So as far as treatment goes, it really depends on how the patient is coming in. If the patient is stable, then certainly you can induce vomiting or consider gastric lavage. We'd recommend inducing vomiting only within the first 2 to 4 or even 2 to 6 hours. Anything longer than that, it's probably made its way out of the stomach, and emesis may not be very helpful. And then if it's within the first 4 to 6 hours, giving activated charcoal can also be quite helpful. Obviously, if you have a cat in respiratory distress, you're not going to do any of those things because it's going to make your cat worse. It could, increase risk of aspiration pneumonia. So if the patient is unstable, you want to start therapy to stabilize that patient. In cats, oxygen therapy can be really helpful. If they're starting to show signs of methemoglobinemia, anemia, they do and will require a blood transfusion. And acetylcysteine is the antidote for acetaminophen. It replenishes your glutathione and then helps metabolize that toxic metabolite into non-toxic metabolites. And so trying to get an acetylcysteine on board quickly can be really helpful. And then doing liver protectants for dogs and cats, SAMI or Denamerin in dogs specifically for liver injury, and in cats it can help with reducing oxidative damage to your red blood cells. Ascorbic acid has been shown to be helpful. Cimetidine has shown to be helpful. Methylene blue can also be used, but from what I found, that methylene blue with an acetylcysteine didn't really make a difference over just using an acetylcysteine. So if we could just give one drug, why not? Why do we want to complicate things? And again, fluids, anti-nausea medication, antibiotics if you're worried about a potential infection, treating the reason why somebody gave the acetaminophen in the first place. All of those things should also be taken into account once you've stabilized that patient. Next, we'll kind of move on to rodenticides, and there are a few rodenticides that I'll be covering today. We'll talk about metallophosphides, bromethalin, anticoagulants, and cholecalciferol. So metallophosphides, this is zinc, aluminium, and magnesium phosphides. These are not as common here, but we have seen it. Any amount of exposure, it should be considered toxic. The way this rodenticide works is, one, specifically zinc phosphide can be really corrosive to the GI tract, so it can induce vomiting, it can induce hematemesis. But then once it is hit the GI tract, typically in like an acidic environment, and just with the GI juices, it is then converted into phosphine, and phosphine gas can be pretty devastating to the body. So it can be, once vomited, if it's in the environment, it can be inhaled and be quite irritating to the lungs. It can also be absorbed to the GI tract and then cause multimodal organ dysfunction. It is primarily excreted through the lungs, and so they can breathe that out, and it can also that can be one way to help eliminating it from the body. So when they've been exposed to it, we can see acute vomiting within 15 to 60 minutes of ingestion. That can actually be a good thing because they're decontaminating themselves, but it's very important if they vomit, either in your practice or at home, is talking to the owners about risk to the humans around them, because we can inhale that gas and get sick from it. It's quite flammable, and it has its odor, it's colorless, and it has like a garlicky odor. So if we're inducing vomiting at the hospital, we make sure it's in a really well ventilated area, and then also talking to owners about the risks of health hazards to themselves. You'll see multi-organ dysfunction, but the respiratory tract seems to take the brunt of it, a lot of it. You can see hematemesis from the corrosiveness of from the metallophosphides, the diarrhea, respiratory distress, cardiovascular instability, and then you can also see neurologic signs such as seizures, circling, and depression. So blood work, we recommend checking it to get an idea of your organ function. You'll see hypo or hyperglycemia, elevated liver values, azotemia, and hemolysis or methemoglobinemia is also possible. So like I said, you want to induce vomiting as soon as possible, but make sure that you are in a well-ventilated area. So outside or in an open area is ideal. Prefer to use apomorphine in these cases over hydrogen peroxide, just because hydrogen peroxide is also irritating to the GI tract. If you don't have any other option, reasonable, if the patient is otherwise stable, to try and use it to get as much of the toxin out of the system. You do not want to increase gastric acidity because the zinc phosphide will turn into phosphine gas at acidic conditions. And so you want to avoid feeding them to decrease secretion of the gastric acids. And then with aluminum hydroxide and magnesium hydroxide, they will turn into phosphine gas at any pH. So not as significant in these cases, but just trying to avoid. So it's meant to say decrease gastric pH. So I apologize. Increase gastric pH, decrease gastric acidity. So using things like antacids, like calcium carbonate, proton pump inhibitors can be really helpful. And like I said, do not feed them because that will increase your gastric acidity. In addition to that, this is really dependent on how the patient is doing. So if the patient is very symptomatic, vomiting, you want to start them on IV fluids, antiemetics, GI supportive care, so things like sucralfate. We already talked about PPIs. If you're noticing damage to the liver, dextrose supplementation may need to be started. If you're seeing hypotension, cardiovascular instability, you may need pressor support. Oxygen is recommended to be started in all patients because the phosphine gas is excreted primarily to the lungs. It's also excreted through the urine, but primarily to the lungs, so you want them to breathe it off, and then also support the lungs because it can be an irritant to the lungs. If they're having seizures, consider benzodiazepines, phenobarbital, Keppra. For tremors, methocarbamol can be really useful with giving these IV. And then watching your electrolytes, potassium and magnesium specifically. Sometimes magnesium can be really depleted in these cases and can increase their cardiac arrhythmias. And so watching and supplementing magnesium as indicated. And then N-acetylcysteine can be helpful for as an antioxidant and then also as an antioxidant, but also as liver support. And then melatonin has shown in vitro to reduce phosphine-induced oxidative damage in the kidneys, heart, and brain, and lung tissue, specifically in rats. So it's not wrong. It's a relatively safe drug to use in dogs. So something to consider as an addition to your therapy. So as far as prognosis goes, if the patient is asymptomatic, anywhere from 8 to 12 hours, they're likely going to do well. If they came in symptomatic, but you were able to stabilize them, treat them, and they get better and they remain well for over 12 to 24 hours, the likelihood is that they're going to do well. We do recommend checking blood work in 3 to 5 days just to make sure we don't see a delayed effect on their liver or their kidneys. And then if they are really sick, they're not improving, then you just take it 1 day at a time. Although if you're seeing multi-organ dysfunction, the prognosis is guarded and it's taken day by day and dependent on their response to therapy. Next, we'll talk about anticoagulants. This is something that we see pretty often here, and also a drug that may be used for poisoning cases fairly often. There are 2 generations or 2 types of anticoagulants. You have warfarin, which is our first generation, and then the second generations are, there are a few that come under the second generation. These tend to be more potent, so higher toxicity at lower doses, and then more longer lasting in our canine and feline patients. So the way anticoagulants work is they affect the production of vitamin K, or the replenishing of vitamin K in our body by affecting the epoxide reductase enzyme and not allowing vitamin K to be renewed by the liver. And so without vitamin K, we're not really able to make new clotting factors that then puts us at risk of developing a coagulopathy or at bleed risk. This does take a few days to occur, so it does take a few days to deplete our stores of clotting factors. So specifically with anticoagulants, toxicities usually happen only about 3 to 5 days after ingestion. It's not an immediate effect. So typical clinical signs are secondary to bleeding. So you'll see, pale gums, lethargy, increased respiratory rate or effort, and then you can see bleeding into almost any cavity in the body or all cavities all at once. So hematemesis, bleeding into the lungs, epistaxis, pericardial pleural, and peritoneal hemorrhage is also very possible. You can see joint hemorrhage. I've seen it into the skin. And then you can also see bleeding into the CNS. So if you're worried about bleeding and you notice these signs, talking to owners about potential rodenticide exposure is pretty important. Obviously, you want to do full baseline blood work to rule out other causes of bleeding or anemia. So typically, you're going to see an anemia. It probably is going to be a regenerative anemia because your bone marrow is not affected. You might see a mild thrombocytopenia. This is primarily because your body is trying to make clots but cannot. And then you'll see a concurrent low protein or low albumin and globulins because you're bleeding. And then clotting times, if by the time you're bleeding, your clotting times are going to be prolonged, your PT is going to be prolonged first because of factor 7. And usually it'll get prolonged only after a loss about 75% of factor 7. If you've lost greater than 80% of factor 7, then you're likely going to develop signs. And the severity of bleeding can just be dependent on how quickly the owner comes in. It could be mild effusion in one of the cavities, or it can be that the patient is hypotensive and in cardiovascular shock or hypotensive shock. So your treatment is based on when the patient presents to you and what is your clinical status of your patient. So if the patient were just ingested the toxin or was just known to be poisoned, then inducing emesis within the first 2 to 6 hours is recommended. Activated charcoal is also recommended. Once you've given that and they're showing signs of bleeding, you definitely want to start vitamin K. Vitamin K will start being effective within 6 to 12 hours after starting it. So you want to get that started. However, if the patient is not clinical, they just ingested the poison, you do not need to start vitamin K because the toxin has not had enough time to have effect on your clotting factors. What you don't know is when you've made this patient vomit and you've got some of the toxin out, you don't know if the patient has vomited out all of the toxin was exposed, or if there's some still left in the GI tract. So what we would recommend is checking clotting times about 36 to 48 hours later to see are they being prolonged or not, and if they're prolonged, starting vitamin K therapy at that point. And again, if you're seeing evidence of bleeding, plasma is recommended as well. You could also consider blood transfusion. Again, it comes down to how much these patients are bleeding, how much blood they're lost, what is their anemia. So you can either do plasma and whole blood at the same time, being cautious of the volumes that you're giving, or if the patient is stable, there's minimal blood loss, start the plasma first to replenish your clotting factors, and then reassess. If the patient is severely hypovolemic, very low PCV, you can start a blood transfusion, and whole blood would be great if you have it, because it has both your clotting factors and your red blood cells. But if you only have packed red blood cells, go ahead and give a packed red blood cell transfusion, then start plasma right after that, starting vitamin K at the same time. So it really is dependent on the stability of your patient, how you approach some of these cases. You could also consider doing auto transfusions if you don't have access to red blood cell products. Plasma is definitely indicated if you are in a bleeding crisis, but you could use your blood from your cavities to replenish your packed red blood cells and maintain blood pressure. As far as additional treatments, if you have abnormal clotting times or coagulation, for warfarin, if you know it's a first generation, 14 days is usually enough. If it is a second generation, you definitely want to do 4 weeks of vitamin K. And then after completion of your vitamin K, rechecking a PT and a PTT 36 to 48 hours later, and to ensure that the toxin is out of the system. If not, and it's still elevated, continuing that vitamin K for another week, rechecking it, and then kind of going from there. Next, we'll talk about bromethalin. Bromethalin is a fairly common rodenticide that we see here. It is one that I don't like because it really doesn't have a good solution if they've gotten into really high doses. It's very rapidly absorbed through the GI tract and then is metabolized by the liver. It's excreted pretty slowly through the body and then goes through this enterohepatic recirculation. And what I mean by that is it is secreted by the bile and then it's reabsorbed once the bile enters the GI tract and reabsorbed by the GI tract, so it can continue to circulate and stay in the system for a long period of time. It is not excreted in the urine, and so fluids. This is one of those toxins that fluids are not really going to be helpful in excretion. How it causes damage to mammals specifically is that it impairs ATP production in the brain and causes electrolyte imbalances that then lead to edema and then neurologic signs. Development of clinical signs is completely dependent on the dose of ingestion. So high doses typically will cause acute onset. So you'll see severe muscle tremors, excitability, seizures, things like that. But if it's a low dose or a chronic low dose exposure, it can take time for signs to develop, and we may not actually see clinical signs until 2 to 3 weeks after ingestion, and it can be, paraparesis, hind limb ataxia, up to, paralysis or coma. So it can look like any other neurologic disease. And so sometimes if they've ingested it, a few weeks ago or a couple of weeks ago, it could be really hard to identify this being the toxin or the issue that caused the animal's neurologic signs. Blood work is usually normal, even if they're fairly clinical. You might want to monitor electrolytes when you start treatment. So if the patient ingested the rodenticide or bromethalin acutely, you want to make sure they're vomited very quickly so we can get it out of the system. Because it goes through enterohepatic recirculation, we do recommend multiple doses of activated charcoal. Start with the first dose of sorbitol and then do subsequent doses every 8 to 6 hours for 48 hours, and then just keeping an eye on the sodium to make sure we're not developing hyponatremia, starting fluids and things like that, in condition to the patient's status. So if they're eating, drinking, otherwise acting normal, don't really need fluids. But if they are not eating, they're vomiting for any other reason, you want to make sure that you're keeping them hydrated. If the patient is starting to show neurologic signs, that's when you want to consider mannitol, midazolam, diazepam, and phenobarbital for seizures as indicated. However, sometimes by the time they've developed really severe neurologic signs, prognosis is pretty poor. So a kind of general rule of thumb, if it ate a lower dose, about 0.5 mg per kg or less, you want to make them vomit, and you can start off with a single dose of activated charcoal. Those patients can go home with close monitoring at home. If a patient ate a higher dose, you want to start emesis, give 2 doses of activated charcoal, and then consider keeping the patient in hospital to monitor or send them home, ensuring that the owners are keeping a close eye on the patient. Anything higher, you want to induce vomiting and do multiple doses of activated charcoal, and maybe monitor those patients in hospital to make sure that they're not developing acute neurologic signs. And then again, warning owners that signs can take a while to develop. So at any point, bringing them in for assessment. The next rodenticide and the last rodenticide is cholecalciferol. This is vitamin D3. It is one of the more common sources of vitamin D toxicosis in dogs. It can cause, at lower doses, mild GI signs, but at higher doses can increase calcium in the body and phosphorus and cause renal failure. It can also cause issues with the heart and the lungs and things like that as well, because of the hypercalcemia and hypophosphatemia. Puppies are more sensitive, and then cats are more sensitive to dogs. Severity is not fully dose dependent, and it's just from patient to patient. So being very careful with monitoring these patients. It is too rapidly absorbed through the GI tract, and it is lipophilic, and so it can have a really slow elimination. So it can remain in the body for weeks to months, and it too goes through enterohepatic recirculation. Once it's converted into its active metabolite by the liver, it increases intestinal absorption of calcium and increases calcium and phosphorus release from the bone. So essentially causing high calcium and phosphorus levels, increasing our calcium phosphorus product over 60, which then leads to mineralization of multiple organs, specifically the CNS, the musculoskeletal system, GI tract, and kidneys. So signs can be seen in about 18 to 48 hours after ingestion, because it does take some time for the calcium and the phosphorus to build up in the system. Early signs could be weakness, depression, and anorexia, but then as it progresses, you're going to see PUPD secondary to kidney disease or kidney injury, vomiting, constipation, dehydration. Sometimes you can see melena. This is again because of mineralization of the GI tract, hematemesis, and if you're seeing hematemesis, typically a poorer prognosis for these patients. And then you can see cardiovascular effects as well. Kidney failure typically occurs 24 to 48 hours after ingestion. As far as diagnostics go, if you're seeing hypercalcemia, if you know it's ingested a toxin, then you know what the cause is, but there's several different causes of hypercalcemia. So making sure that you are ruling out other causes of hypercalcemia, doing a total and ionized calcium, checking your phosphorus levels. It will typically go up before the calcium levels, and then monitoring your renal values, urine analysis, looking for a low USG, calciuria, evidence of kidney damage. Obviously, again, if they have just ingested it, inducing emesis quickly can be really helpful. Doing activated charcoal, repeated doses for large toxicities, and then monitoring calcium and phosphorus and renal values every 24 to 48 hours, 4 days post-ingestion. So if the patient comes in asymptomatic, you induce vomiting, you start activated charcoal, and it's reasonable to send these patients home if you think you have decontaminated them well, and then just keep an eye on their calcium and phosphorus levels, and renal values, and if they're remaining asymptomatic, the likelihood is that they're not going to develop injury as long as their values remain normal. It is if they come in with elevated values, they're symptomatic, or they develop high calcium and phosphorus after you sent them home, that's when you institute treatment. You want to start IV fluids, usually normal strength saline, 0.9% saline. Furosemide can be helpful to help with elimination. Prednisone decreases bone reabsorption and intestinal absorption of calcium. It also helps increasing renal excretion of calcium. I usually start lower and then can increase it as necessary. And then phosphate binders for the hyperphosphatemia. Aluminum hydroxide, anywhere between 30 to 90 mg per kg, and you ideally want to give it with food. Keep these animals on a low calcium and phosphorus diet for about 4 weeks. And then if they are severely affected, so if you've instituted these treatments and they're not getting better, then you definitely want to consider a bisphosphonate. We use zolidronate pretty often with whatever you have access to, and then continuing them on IV fluids. If they're improved with their initial therapy, saline, furosemide, pred, then you can send them home, but have them come back, every 24 hours to monitor their calcium and phosphorus and renal values for about 4 days. And then if they're doing well, have them come back in 2 weeks, again, to just make sure that all of these values are remaining normal. Now, sometimes we don't know what rodenticide they got into. So your owner brings them in, there was something on the ground, or they bought a rodenticide a long time ago, but they don't know what type. In those cases, if it's been an acute exposure, again, induce vomiting, because if there's a risk of metallophosphites, make sure you're doing it in a ventilated area, and then don't feed them, obviously, to reduce gastric acidity. I would do activated charcoal, and depending on how much you have, like how much comes out of their GI tract, either do multiple doses or at least one with sorbitol, and then check your blood work, make sure your baseline blood work is normal. So renal values, calcium, phosphorus are all normal. Make sure they're not acting neurologic, and then reasonable to discharge those patients if they're aclinical, but having them come in every 24 to 48 hours to monitor renal values in case this was cholecalciferol. Maybe even start them on a GI protectant if this was a metallophosphide. And then, treat them as symptomatically as necessary. And then in 2 to 3 days, check a PT to make sure that they're not developing any signs of anticoagulant rodenticide toxicity. On the flip side, if these owners are not ones to come back, you could very safely start them on vitamin K, and I would just do 30 days of it and have them recheck, after the medication, as long as the patient is otherwise doing well. So I think if you don't know what toxin or what rodenticide you're dealing with, trying to treat them for all and monitor for all within the first few days would be very reasonable. Obviously, if they're starting to show clinical signs, then you'll hone into which one it is based on those clinical signs and blood work abnormalities. And then the last topic that I want to talk about is organophosphates and carbamates. This one I am not as familiar with, just have not had any personal or clinical experience. So these are from notes from school, but also from online research. So organophosphates and carbamates are insecticides, and they can be used in kind of farms, agricultural settings, households, but they're also sometimes used on animals for pest control. There are several different kinds out there, so they have variable toxicities and lethal doses. If you're potential exposure, I would deal with it and treat them rather than waiting for clinical signs to develop. Younger animals are more susceptible. It can be absorbed through the skin, the respiratory tract, and then the GI tract as well. They are all or mostly cholinesterase inhibitors, so they increase acetylcholine within the preganglionic and postganglionic junctions. Organophosphates typically have to go through a metabolism in the liver by the cytochrome P450 or flavin into its active metabolite. Carbamates are already active when they are entering into the system. So there is a little bit of a lag in clinical signs. However, if it is a very high dose of organophosphate exposure, you'll see clinical signs within a few minutes of being exposed. Organophosphates tend to be more lipid soluble as well, so they can cross into the blood-brain barrier much more quickly. So, like I said, they're cholinesterase inhibitors. So they break down the enzyme that removes acetylcholine from their receptors on the postganglions or postsynaptic neurons, and so therefore causing stimulation of those neurons to continue. There are three syndromes or types of clinical signs that can develop, basically associated with the type of receptors being affected. So you can see our muscarinic signs, where you can see salivation, lacrimation, defecation, but in addition, you'll see anorexia, coughing, meiosis, bradycardia, abdominal pain, vomiting. Then you can see nicotinic signs, which are going to be more of your tremors, your agitation, sometimes paresis, tetanus, stiffness as well. And then when your CNS is affected, you'll see hyperactivity, agitation, restlessness, and seizures. Onset is dependent on the dose and the route of exposure and formulation of the organophosphate or carbamate. So if it's oral, you can see signs within 10 minutes. These are really high doses. For dermal exposures, it can be 12 to 24 hours before you're starting to see signs. The respiratory tract tends to be pretty affected in these cases eventually. And so death is often from respiratory compromise, from bronchiolar constrictions, from secretions of the respiratory tract, and then paralysis of the diaphragm as well. There's also an intermediate syndrome that can occur either 24 to 48 hours after acute signs develop, or sometimes it can occur immediately. And this usually happens because the receptors build up a tolerance to the acetylcholine that remains. And it usually only happens at the muscarinic receptors. So we're not going to see, so in these cases, you don't typically see the classic SLUD signs. You're going to see more of the nicotinic signs, so that muscle tremors, the abnormal posturing, stiffness, things like that. So diagnostics, you want to do a minimum database, but your blood work could be pretty normal initially. There are acetylcholinesterase assays. They do take a couple of days to come back, so you won't get your answer right away. So a lot of your diagnosis is based on clinical signs, but then also patient history, client history. So treatment, if it's a known exposure and you're starting to see those muscarinic signs, salivation, lacrimation, urination, or defecation, you do want to do kind of high dose atropine, 0.1 to 0.5 mg per kg. Start with a quarter dose, and that's given IV, and then give the rest IM or sub-Q, and then assess for improvement of clinical signs. If you are sure this is an organophosphate toxicity, you should give 2-PAM, which reactivates the acetylcholine esterase enzyme. This is not typically necessary for carbamates because carbamates irreversibly bind to the enzyme, whereas organophosphates irreversibly bind to these enzymes. Once the patient is more stable, so not showing significant, like they're responding to your atropine and 2-PAM, then you can consider decontamination, so emesis, activated charcoal with a cathartic. If they're stable, you can do a gastric lavage. If they had dermal exposure, you want to bathe these patients. And then supportive care as necessary based on how the patient is doing. If the patient is not doing, if the patient is unknown exposure but you have suggestive signs, then you can do a test dose of atropine. You will do what we typically use as a pre-anesthetic dose, 0.02 mg per kg, and then watch for either improvement or non-improvement of signs. If you see improvement of signs, so the heart rate increases, salivation stops, the eyes dilate, then this is actually not an organophosphate or a carbamate. They require higher doses to see improvement. So if you don't see improvement, then you can use that previous protocol and see if they improve with the higher doses of atropine. And if they do, then that's likely an organophosphate. If you start with the really high dose, you can cause atropine toxicosis or toxicity, and that can lead to hyperthermia, redness of the skin, agitation, intestinal stasis, sometimes seizures, which you then will have to treat supportively. So just being really careful with how we're using atropine to determine if this is an organophosphate or not. 2-PAM, if you're suspicious if this is an organophosphate or it's a carbamate, go ahead and give it. If you're not, do the atropine test and then decide if it needs 2-PAM. Prognosis really just depends on dose and time of exposure. So if the patients are aclinical coming in or are mildly clinical but respond really well to your treatment, then they will do well. But if they're severely clinical coming in, there's been a delay in treatment. If they're cardiovascularly unstable or having respiratory compromise, then obviously those patients have a poorer prognosis. That's it. I think I took the whole hour, so I apologize.
Yeah, thank you, Dr. Akshaya, for your elaborative presentation. And now there are a few questions by the participants. So one of the questions, the use of intravenous lipid emulsion, what are the precautions you need to follow? I will answer some of them, Maller, Akshaya,
Okay.
and
Sure.
then I will come back to you.
Yeah.
So the parameter to be checked while using intravenous lipid emulsion, you need to check triglycerides, lipase levels, liver enzyme you need to check, bilirubin level you have to check. If you suspect a case of pancreatitis or cholecystitis, and some of them is because some of them they also allergic to some of the patient they allergic to intravenous lipid emulsion. You need to check for allergy and fever. What they do normally, they give a small bolus 1.5 ml per kg. Slowly they give for initially. Then after that they increase the speed to 8 to 15 ml per kg over 60 minutes. You need to give very slowly. And any other thing you want to add on, Akshaya?
Yeah, I think the other thing is taking into consideration like we have a lot of schnauzers here. They are high risk of pancreatitis, things like that. So yeah, just being cautious with the patient selection, and then rate of administration can also be helpful in some of those cases.
The next question is methylene blue dose in paracetamol toxicity. Actually, the dose is 1 to 5 milligram per kg body weight. You have 1 to 5 milligram. You need to give very slowly. And is there anything you want to add on, Akshaya?
No, I've never used methylene blue, so because we have access to N-acetylcysteine, so I actually haven't had experience with that. So
Okay.
I'll defer to you.
So you mentioned in your presentation, that's the reason.
Yeah. And the methylene blue, at least from what I found, didn't have any, like, so N-acetylcysteine is your true antidote, and it didn't have any better results with methylene blue and N-acetylcysteine than just N-acetylcysteine alone. So that's why we just typically will go with that, but everybody treats a little bit differently. So
yeah. So another question, so what are the pressure support normally used in the hospital?
like
Maybe
vasopressors.
hypertension, what do you do? Hypotension, what do you do? Hypertension,
Yeah, so
normally we manage with the ACE inhibitor and diuretics. Hypotension, no, the low BP, we use intravenous fluids and sometimes blood transfusions. And there are occasions we go for norepinephrine and vasopressin. So that's the way we manage. Any other thing you want to add on this?
Yeah, so it's important to know why, what you're treating. Like, so why are they hypotensive? So if it's because they have, hypovolemic, then yes, giving fluids, blood if they're bleeding, plasma, so poloid support can be really helpful. And then assessing to see if they're improving with, fluids. If they're not, then decide, not giving them too much fluids and deciding whether they do need a pressor. So then, if you've done your shock doses, like 1 or 2 shock bolus doses, I should say quarter shock doses, and they're not responding, then deciding whether you do need blood products, you do need colloidal support, and or do you also need vasopressors. So it really depends on why the patient is hypotensive, what your treatment is going to be. And then hypertension, typically if they're acutely hypertensive, again, trying to figure out why they're hypotensive. Is it just because they're anxious or agitated? Sometimes you can use acepromazine in some of these like stimulatory toxins. And if that's not working, and if the hypertension is truly from either kidney disease or idiopathic, then yes, ACE inhibitors, telmisartan, amlodipine, again, depending on how they're responding and what the cause of that hypertension is. So just basing it on your patient.
Okay, the another questions, PPT of this presentation, shall we get it? Yes, you will get the PPT presentation shortly by the Hatvet PHARMA YouTube channel, you will get it. Another question by another viewers, and auto transfusion in anticoagulant toxicity, explain. The process of collecting and reinfusing a patient's own blood is the auto transfusion. Is that
so you can do an auto transfusion from either the chest or the abdomen. So obviously you want to be able to do a thoracocentesis or an abdominocentesis. So using if it's a bigger patient, a large gauge catheter or fenestrated catheter to get access. Then typically there's a couple of ways you can do it. One is you can attach a extension line and pull up the blood in syringes, and you always want to do this all sterilely. So the person who's doing the thoracocentesis is sterile, the person who's collecting the blood is sterile. And then so you pull up that blood, and then you can give that directly into their IV access, their IV catheter. So you don't need a filter because this is blood that has been accumulating in the cavity. It's not going to clot. So you just pull it up sterilely, and then you give them boluses as you're getting it. If you want to be really fancy, you can get like a 3-way stopcock and have one line coming out of the body cavity that you're aspirating from, and then the other line going into the patient. And so the person is pulling it up, changing the stopcock, and pushing it in kind of all at the same time. The big things are you need to be able to collect the blood from the cavity sterilely, and then you obviously need IV access to give that blood. You want to be careful. I mean, if the patient is severely hypotensive, you can bolus that blood, but you can also run the blood, at a rate to, if you don't need to bolus it, if you don't need to get vascular stability quickly.
Then another question, rodenticide, how long it will stay in the stomach? So there are information, rodenticide in the form of bait pellet. They say it can stay in the stomach for 4 hours. If it in the bar form, it can stay in the stomach for 8 hours. So these are all the, any other information?
I feel from personal experience, bromethylene, for whatever reason, stays in the stomach for a long time. Even if they're over 6 hours, I'll make them vomit. And sometimes we just don't know when they ingested it. So even if they've ingested it sometime during the day, it's never wrong if the patient is otherwise stable to just make them vomit, because that's one way you can get it out or get some of it out to reduce the exposure to the toxin.
Then another question, what should we give in carbamate poisoning, Akshaya? Antidote they are asking, carbamate poisoning.
Yeah, so I guess I haven't had any personal experience. Atropine, if you're seeing muscarinic signs, as far as I can tell, 2-PAM is not typically used because the signs decrease quickly, because they reversibly bind to the enzyme. But I will have to defer to somebody who's actually treated these to be sure.
Amshini, so what is the antidote you use for carbamate poisoning? Any experience you have? Amshini, can you hear?
Yes, sir. Sorry, I was trying to unmute myself.
Problem.
No, I have not. I have OPC poisoning I've seen in Mumbai, but not carbamate poisoning either.
Okay. So that's all the questions asked. The rest of the other thing you replied it. Anything you want to add, Amshini, related to these 3 poisoning in your experience?
Yes, actually, that was really excellent. Thank you so much. That was very helpful. Good refresher for all of us, I think. Just a really quick thing. The ropinirole, I don't know how you pronounce it, whatever that drug is. That is, it's available in India, but there's some studies, I think, from 2024, 2025. They're actually not as effective as apomorphine. Apomorphine is widely available in India, very cheaply available. I think most of the doctors here already have access to it. So if you have apomorphine, just continue to use apomorphine. It's good enough.
Yeah, and I don't it's a new drug. It's very expensive here, so I don't actually use it that often. I also prefer Apo. I also find that the ropinirole causes a lot of vomiting. So they have the initial vomiting, and those patients stay very nauseous even after 30 minutes after. So metoclopramide is the reversal for it. So you can reverse that nausea effect, but not my favorite. And you're exactly right. Even Apo here is much cheaper, so it's what we would use. What I use, I guess.
Okay, Akshaya and Amshini, thank you very much for your valuable information. I hope you'll also, whenever you are free, you text me your availability. We'll catch hold you so that you can interact with our group, and you can give a lot of input in this. So this presentation by the Akshaya Maller is over.